Thank you. It's a great pleasure to be here, and I've really enjoyed the talks that I've heard, and I'm sorry I wasn't here at the beginning of the session. So I'm going to spend just a quick sort of 10 or 12 minutes contemplating how we can translate what we've learned in BRCA1 and 2 mutated high-grade serous ovarian cancer to the wild-type setting, and I'll discuss what we mean by that as well. So it's clearly a more complex picture, and the things I'd like to think a little bit about are how we define the likely benefit from PARP inhibitors in wild-type BRCA1 and 2 high-grade serous ovarian cancer, how we define other biomarkers which may predict response to PARP, and particularly how we define interactions within the immune system or with the immune system. Now, you've covered a lot of that beautifully today. I mean, I just really enjoyed Tarek's talk and then the subsequent discussions that we had. But the challenges then that I will contemplate ever so briefly are how do we maximise or generate a homologous recombination DNA repair defect? How do we prime or orchestrate an appropriate immune response? How do we combine therapies to hit multiple targets to generate sufficient synthetic lethality? And what is my definition of sufficient? Well, nothing less than our ultimate aim, which is to achieve and maintain the state of super response to PARP inhibitors. And I'm sure that you'll all agree with me, that most beautiful presentation on super responders, any one of us who've treated patients who are indeed super responders, and I have a couple of patients who've been 8-year super responders, that is what we want for all of our patients. And, you know, that bottom line would be heresy and false hope, and I'd be accused of being up here under false pretenses if I didn't have a couple of those patients. But we don't want a couple, you know, we want a lot more than that. So back to the beginning, how do we define the likely benefit from PARP inhibitors in wild-type BRCA high-grade serous ovarian cancer? I have to flip through very quickly the data that we have. So these are a couple of phase 2s and all phase 3 trials in ovarian cancer, but the two that are relevant for today then are the two phase 3s that include BRCA1 and 2 wild-type patients, and they're the NOVA trial and the Ariel 3 trial. So firstly, we just have to quickly remind ourselves, how do we detect DNA repair defects reliably in italics, apart from looking for individual gene mutations or methylation. And that's because we need to keep track of which BRCA1 and 2 wild-type high-grade serous ovarian cancer patients should be responding to PARP, because of course we wouldn't expect all high-grade serous ovarian cancers to respond. We don't know which cancers are capable of responding, so initially we needed to include all of these cases in clinical trials so as not to miss potential responders. So originally, for example, Clovis developed together with Foundation Medicine this genomic-wide loss of heterozygosity marker, and they developed this in the Ariel 2 phase 2 trial to use it in the Ariel 3 phase 3 trial. And you could see in the BRCA mutant cases at the top these large areas of genome-wide LOH, and they hypothesised that there would be BRCA-like cases within the BRCA wild-type cohort that would look like the BRCA mutant cases, and they would have wider regions of LOH than in the biomarker-negative group. Now, simultaneously, Myriad were developing a biomarker which included that LOH score, but also included two additional features, telomeric allelic imbalance and large-scale state transitions. And with those three readouts, developed an HRD cutoff with a score which was 42, which always reminded me of a book. But anyway, Hitchhiker's Guide to the Galaxy, and of course that wasn't a real answer, but anyway, I won't get off on a high horse. So if we look at the NOVA results, these are the BRCA mutant results, and I just draw your attention to the median PFS of 21 months as compared with 5.5 and a hazard ratio of 0.27. Now you'll recall that prior to the PARP inhibitor era, we never saw a hazard ratio of 0.27. We did sneak in a bevacizumab hazard ratio of 0.35, but we never had one of 0.2. So non-BRCA mutants, so this is where we're heading towards with BRCA wild type, PFS of 9.3 months with a hazard ratio of 0.45, but we need to break that up, and when we do that, we then get a non-BRCA mutant but HRD positive of 12.9 with a hazard ratio of 0.38. But now if we break that up and take out what they call the somatic BRCA mutants, now there you have a very high PFS median of 20.9 with a hazard ratio of 0.27. So really we know those are going to be like the G-BRCA mutant. So here we are, BRCA wild-type HRD positive with 9.3 months with a hazard ratio of 0.38. So we know that those are impressive relatively, 9.3 versus 3.7 months. And here is the HRD or biomarker negative, 6.9 months versus 3.8 with a hazard ratio of 0.58. So it's arguable as to whether those HRD negatives are really getting a true benefit or whether we've just got patients in there that should be in the BRCA wild-type group and the biomarker isn't quite good enough. That's certainly what I think is the case. Now, if we quickly look at the areal 3 group, you can see the T-BRCA group, which include the BRCA mutant cases. Again, a very good hazard ratio of 0.23. And a median PFS of 16 months or 17 months almost versus 5 months. Now, there was some selection or enrichment for platinum sensitivity in the NOVA trial, so there's probably overall not too much difference between that and the NOVA outcome. But if you look at this BRCA wild-type HRD positive group, 0.44 hazard ratio and 9.7 median PFS. So these are the curves. This led to a recent FDA approval for platinum-sensitive recurrent all-comers for rucaparib just last month. And the take-home here probably is treat all platinum-sensitive relapsed high-grade serous ovarian cancer in the maintenance setting, as long as they respond, of course. So we have to watch this space for PBAC, because in Australia we still only have approval in the germline setting. So if you compare directly NOVA with areal 3, you can see what is encouraging is that these numbers are somewhat repetitive. We now see for G-BRCA, T-BRCA or S-BRCA, you can see that we have 20 months or 16, 17 months versus around 5 months with HRs of around 0.2. So very impressive numbers. But for today's talk, the wild-type BRCA HRD is around 9 months for the HRD positive with hazard ratios around 0.3, 0.4. And for the HRD negative, biomarker negative, it's less impressive, and probably you've got leakage with a biomarker that's not quite good enough. So I'd like to move off that to just talk about the other biomarkers that may predict response to a PARP inhibitor. You've seen this, I'm sure, many times. So that top red corner are the cases we know a lot about, BRCA1 and 2 germline and somatic mutations. The green corner is where we have a fair idea of what's going on. This is promoter methylation for BRCA1 or RAD51C or D. RAD51C, and then we have mutations in other genes that we know quite a lot about, genes in the HR pathway. Down the bottom, possibly HR deficient, these are lesions that we are not quite convinced about, things like PTEN, MZ amplification. And over in the blue on the left-hand side, I have lesions that we'll come back to. These are about replication, instability, and we want to talk about those in terms of combinatorial lesions that we'll talk about in a moment. Defining interactions with the immune system is something I don't have time to do, and we've already discussed about, and it does appear, as I was keen to see on one of Tarek's slides, as an issue that is to be considered when you talk about actually looking at biomarkers of immune readouts, because you could drive incompetent DNA repair and drive neoantigenicity. So it is something to think about, and data is starting to emerge about priming, which I'll talk about in a moment. So if we think now about the challenges, how do we maximise or generate an HR defect? This is the key to maintaining long-term PARP inhibitor response, and we have to think about mechanisms of DNA repair inhibitor resistance. I don't have time to talk about this today, but the maintenance and preventing reversions of mutations themselves, so preventing secondary mutations such as were discussed earlier, preventing evolution of DNA repair pathways such as loss of NHEJ or changing from NHEJ, preventing mutation of drug binding sites, preventing loss of methylation. Now, tumour heterogeneity is a huge issue, as you've heard. Treating early, don't wait for loss of HRD. All of these things are incredibly important. But the one example I wanted to talk to you about today was something that Elaine Sanage and Rick Pearson have spent a long time working on, and this is inhibition of RNA polymerase I transcription with a drug called CX-5461. Elaine presented this data at ANSCOG a month ago, and this drug is very interesting because it activates DNA damage responses and enhances PARP inhibitor efficacy in vivo. Now, these are PDX from our lab, and on the right-hand side, you can see a BRCA2 mutant PDX, but in the middle, you can see a PDX, which is BRCA1 and 2 mutation wild type. That's because there is a methylation defect in BRCA1, and we're working on other BRCA1 and 2 wild type PDX. So this is a drug that can potentially create an HR defect, and this would be an example where in combination with a PARP inhibitor you can actually invoke an HR defect. So we're very excited about this and working with Elaine and Rick on it further. So how do we prime or orchestrate an appropriate immune response in wild-type BRCA1 2 high-grade serous ovarian cancer equal to that seen in BRCA1 mutant high-grade serous ovarian cancer, for example? And I'm just going to pause for a moment and look at SOLACE and SOLACE 2. So SOLACE is a trial that is complete. It's been presented at ASCO and is the manuscript's just being finalised at the moment. This was a phase 1 trial of olaparib and low-dose oral cyclophosphamide, and the tolerability studies showed that we could combine these two drugs and that we saw enough efficacy to suggest that this is an active combination and worthy of further study. The reason we were interested in looking at this combination is because we were convinced that we would see priming, some immunologic activity of this combination, and also low-dose DNA damage and also effects on anti-angiogenesis. We were also interested because, again, if we looked in the PDX from my lab, having looked at 14 PDX, we were struck by the fact that we only ever saw responses in DNA repair defective PDX. And this was almost all or nothing. There was one PDX that we were still trying to understand better, whether there was a DNA repair defect or not. But even if we simply said revealed enrichment, we wanted to understand why this was so. So SOLACE 2 is a phase 2 randomised trial which has now been funded by AstraZeneca and also by Oasis. And we're looking at immune priming by low-dose cyclophosphamide and olaparib. And we're looking at whether priming by those two drugs prior to olaparib alone, prior to combination therapy with olaparib plus durvalumab versus olaparib alone in asymptomatic platinum-sensitive relapsed high-grade serous ovarian cancer will allow the emergence of more super responders to occur. Because we don't believe we've got biomarkers right for picking homologous recombination defective high-grade serous ovarian cancer, we're enriching for HRD. So the translation is all focused on immune priming by these two drugs, and Magda Plabansky, our immunologist, is responsible for the translation. So we're very encouraged by the preliminary findings of Mediola in mutant BRCA1 and 2, but we're really focused on looking in the BRCA wild-type population here. So patients will get 3 months of priming and a lot of fortnightly blood tests. So this is a very exciting study. We're just submitting to ethics at the moment. So finally, how do we combine therapies to hit multiple targets to generate sufficient synthetic lethality? And here we're really interested in the cyclin E population, but also c-Myc and Myc-N. So we have some preliminary data from prexasertib in this space, and a number of sites have this study open. This is data recently published in Lancet Oncology from Elise Cohn's group. And here, there were really reasonable responses using this drug, which is a CHEK1/2 inhibitor. And of course, in high-grade serous ovarian cancer, you have ubiquitous TP53 mutations. If you then look at the cases where there is cyclin E overactivity, 63% of cases had cyclin E overactivity, and those cases had a PFS of more than 6 months. So there is no doubt that you can look at oncogene overexpression and then look again and say, can we do something about that? So PARP inhibitors in this setting, in subsequent translational studies, had really relevant biologic activity associated with DNA damage, replication stress, and CHEK1 inhibitor in that setting led to mitotic catastrophe, suggesting that the combination of PARP inhibitors and CHEK1 inhibitors together would be a very effective combination. So this would suggest that if we are very rational in our selection of combination therapies, we should be able to take that one step closer to being able to choose better optimal combination therapies for our patients. So if we were to achieve and maintain the state of super response in our patients, we should be trying to do all three things. We should maximise and generate an HR defect. That may involve choosing an additional drug, but certainly choosing our drugs and treating up front. We should be priming and orchestrating an appropriate immune response by choosing very carefully the immune combinations that we need. And we should be rationally choosing additional combination therapies based on the phenotype of the cancer. And if there are oncogenes overexpressed, or if the cancer is a stromal C1 cancer, we need to think very carefully about sequencing in additional combination therapies. So there are many people involved in the additional translational work that I've touched on, and they appear on these slides. I think there's probably maybe 1 minute left, or not. 1 minute.